Okay, let's get started. And today's workshop is on recovery, and we have Fiona Eng, and who's going to do the workshop. So she's going to talk about her work for the first few minutes, and she wishes to take questions at the end. Just to introduce Fiona, Fiona Eng is a PhD candidate in the School of Psychology at the University of Wollongong, and she's also an associate research fellow in the Project Aid Strategy for Personality Disorders. Her research focuses on understanding the lived experience and recovery journey from BPD through the perspectives of consumers, carers, and clinicians. So, over to Fiona.
Thank you so much for that introduction. Thank you all for coming and inviting me to give this presentation. I'm very honored to be here today. First, I'd like to acknowledge and pay my respects to the Gadigal people of the Aurora Nation on whose land we meet today. I'd like to also pay my respect to the elders past and present, and also to all Aboriginal and Torres Strait Islander peoples. I'd also like to acknowledge those here today who have a lived experience of being a consumer or a carer with mental illness, particularly those with BPD. Your experiences really help us to kind of understand what needs to be done to improve services and treatment, so I'd like to pay my respects to that. So before we begin, we've had a lot of talk about what recovery means in BPD and what it might entail, but we've had a lot of professionals and academics talk to you guys about what it is, but we haven't really heard about what you think it is. So I'd like to take about 10 or so minutes to kind of really hear about what you think recovery is. So what does recovery mean to you? Anyone? Yeah.
It's working.
Great. Bob Burke, we have a carer support group in Adelaide.
Yeah.
And what we've found with our support group is that it's not helpful to talk about recovery without further expansion, because people think in terms of physical illnesses and it's all gone, total recovery. But we found that a consumer speaker a couple of years ago helped us with that by saying, look, I still have symptoms of BPD, but I consider that I've recovered because I can manage them.
Yeah, and I think that's...
So I think it's management of the illness in the presence of symptoms that defines it fairly well for me.
Yeah. Anyone else?
Sorry, I hope this isn't going to be contentious. I don't like the term recovery, and I think for the reasons that you just explained, that I guess the term recovery in the context of any other sort of illness does mean that it's better, and now you don't need to worry about that anymore. So to me, I would say, yes, you get better at managing it and living with it, but by definition, that to me is not recovery. That's managing it and living with it. So I have a massive issue with the term.
Yeah, and we'll definitely come back to that point in a moment.
I would say that managing it, living with it, that I live better with it now, rather than recovering.
Nice.
Hi, my name's Daniel Bentley. I coordinate the Personal Helpers and Mentors program in North Brisbane, which is an outreach mental health service. And we also run some Wise Choices groups, so thank you Spectrum for the Wise Choices program, which is a fantastic program. As someone who works in a recovery-oriented practice, being the FAMS program, I've learned to understand recovery as being the journey rather than an endpoint, that it's about being curious about your life and what you can do. So it's not being deficit-focused and focusing on illness or disability, but focusing on ability, and it's about quality of life. I think that's something that's been really instilled into me through the acceptance and commitment therapy work that I've done as well as my own life experience. Going through addiction and recovery is about quality of life and about having that, a life which is connected to your values, that has meaning and purpose, and it's about relationships.
Yeah. Okay. Any other comments about what you think recovery is?
had a new brainwave, have you?
Sorry. I've got to say the word journey annoys me even more than the word recovery. No, journey does not work for me. No, I think...
Is there a better word that you would use to describe?
I don't quite know. I've noticed the word journey gets bandied around a lot in a lot of different contexts now. Everything in life is a journey.
Yeah.
And I guess to me, I would say that I battle with BPD.
Okay.
I wouldn't say it's a journey. A journey sounds quite romantic and poetic and something that I choose to go on.
Too PC.
Yeah, it doesn't work for me.
Alrighty.
So yeah, I would say I battle with BPD rather than that it's a journey.
Yep, sure.
I won't-
So we have time for one more, maybe? Bryn, behind you.
Hello, I also suffer from BPD, and I don't suffer from it. I see it as having been a blessing, and I don't believe in saying it is a battle, because that actually creates an inner conflict between you and another part of yourself, and that only increases the tension. I believe recovery comes from actually letting go and accepting yourself exactly as you are, and loving every part of yourself,
Yeah.
and seeing the blessings and being grateful for what has been given to you and how you can use it to transcend whatever difficulties you have in life and use it to create more good and raise consciousness in the world.
Yeah.
So thank you.
Nice. So it sounds like everyone has a very different kind of way of understanding what recovery means. So it's not necessarily just the reduction of symptoms or like the amelioration of symptoms. It's really an individual process, I won't say journey, that is defined by you, the consumer, or the person with lived experience. So these are some of the things that people have told me about. So being able to relate to others, so decreasing symptoms is there, things like being able to go to work, having relationships, understanding who I am. So there's some of the examples that some people have, told me about. So in the literature, we understand there are multiple dimensions associated with recovery. However, the clearest divide has been associated with clinical and personal notions. So clinical recovery refers to the more traditional conceptualizations of recovery and primarily focuses on reducing symptoms and also the return to previous levels of functioning. So within the BPD literature, there has been a very strong focus on this concept. And there's been a very diverse range of studies that have specifically looked at this concept. So we touched on this a little bit this morning. So for example, there have been a lot of studies that have looked at the effectiveness of treatments, particularly the big four, so things like DBT, mentalization-based therapies, schema, and also transference-focused psychotherapy. And one of the really good things that have come out from this is that all the treatments seem to work. So regardless of which treatment you engage in, people do seem to improve symptomatically. Also, within the last 20 to 30 years, there have been a number of longitudinal studies that have followed people up who have a diagnosis of BPD in order to try and describe what the natural course of the disorder looks like. So the longest running one has recently hit its 24th year, and it's currently being done by Mary Zanarini and her colleagues out at Harvard. So they recently presented their findings for their 20th year of following up their participants. And from baseline to the 20th year, they found that people with BPD do improve symptomatically, such that about 74% by the 6th year of follow-up have already experienced remission. By the 20th year follow-up, they found that about 60% of their participants reached a state of recovery. However, they did have a very tight criteria for what they called recovery. So this included factors such as being in remission for at least 4 years or something like that, having at least one emotionally close, sustaining relationship with either a friend or a partner, but also being able to work and or go to school continuously on a full-time basis. And although these findings are very promising, there are some concerns over the efficacy of these treatments for outcomes beyond symptom change. So although we know that these treatments work and people are getting better as a result of engaging in these treatments, we don't really know in what other areas people are also improving in. So the concept of personal recovery arose from the consumer movement in the 70s from the US, and it's very much seen to be a very individualized concept. So trying to define what personal recovery is has been very difficult because it means different things to different people. But the most widely accepted definition of personal recovery has come from someone called Anthony in 1993, and it's been described as a deeply personal and unique process of changing one's attitudes, values, feelings, goals, skills, and/or roles. It is a way of living a satisfying, hopeful, and contributing life, even with the limitations of the illness. So this concept really focuses on the consumer, and it places the lived experiences at the center of care. And it really does support that there are multiple aspects that go into supporting a person through their recovery. So for example, that might include services, clinicians, families, carers. And as such, it really highlights that there is not one way or one path that leads to recovery. It's really everyone goes on their own journey or process. So a number of state and national strategic plans and frameworks have emphasized the need to focus on personal recovery in health services, and there's also an increasing recognition of the support network, for example, carers and family members in the recovery process, and I think quite a few presentations this morning have touched on this. So for example, the Living Well strategic plan from the New South Wales Mental Health Commission endorses a consumer-driven approach which focuses on recovery and places the lived experiences of consumers and carers at the centre. This has also been reflected in the National Framework for Recovery-Oriented Mental Health Services and also the New South Wales Carer Strategy. But when we think about personal recovery in BPD within the research literature, the consumer and carer voice has been very minimally represented, and so we do need to develop a more holistic framework and understanding of what recovery from BPD actually entails. And this has been supported by the NHMRC clinical practice guidelines, where it's specifically noted that we need to define what recovery actually is. We need to also identify what the treatment priorities of consumers are, and we also need to understand BPD through the family and carer perspectives. So in order to start that process of developing a more holistic framework for understanding recovery, we firstly set out to systematically review the literature to gain an understanding of what is already out there in the research literature. Specifically, we wanted to know about the longer-term outcomes of consumers with BPD and also how personal recovery has been conceptualised through the perspectives of consumers, clinicians, and family and carers. So our review followed the PRISMA guidelines, and it was pre-registered, the methodology. Articles that we used to, articles that were included in the review were identified through electronic databases, reference lists, and also some that were known to our research team. And we did have a very strict set of rules as to what kind of articles we included or excluded into the review. So we only included studies that contain the perspectives of either consumers, clinicians, or family or carers. The study had to focus on BPD as the main disorder. This study also had to examine the recovery process through either remission or the remission of symptoms or through consumer experiences. The consumers that were represented in the studies had to either be based within an inpatient or a community setting, and the studies had to adopt either a qualitative or a longitudinal methodology. But because we were interested in the longer-term outcomes of consumers, we only included longitudinal studies if they have a follow-up period of greater than 5 years. So using this inclusion criteria, we included 19 studies for review. So this was made up of 16 longitudinal studies and 3 qualitative studies, and it represented 11 unique cohorts or 1,122 consumers with BPD. So the consumers represented in our review were predominantly female from a Western background with an average age of about 30 years. Most by the time by follow-up period, most were never married and most were not engaged in a vocation. So our findings suggest that there are multiple factors that go into understanding recovery from BPD. From a more clinical perspective, it includes factors such as remission, recurrence, diagnostic retainment, and also functioning. Whilst personal recovery involves themes such as the willingness to engage in the recovery journey, but there was also a lot of discussion about what recovery from BPD actually entails and how it could be conceptualized. In terms of the support network, the review didn't identify any studies that look specifically at recovery, so it's definitely an area that needs a lot more work. So in terms of remission, recurrence, and diagnostic retainment, we did see that there were many differences in how researchers measured and evaluated these concepts. So there were differences in terms of the follow-up length, the diagnostic tool that was used to assess outcomes, the dropout rates, but also the setting in which patients were recruited, so the difference between inpatient and outpatient settings. But because of these differences, it makes it really difficult to definitively say this proportion of consumers will experience remission or will relapse or will retain their diagnosis after so many years. So we can only really report on the range of rates that were from the included studies. So from our review, the follow-up period ranged between 5 to 27 years, where about 33 to 99% of consumers experienced remission, whilst 10 to 36% experienced a relapse, and about 8 to 67% retained their diagnosis. We also found that there was an increase in functioning. However, the scores at follow-up do indicate that consumers do have ongoing difficulties with this. So overall, the findings on clinical recovery suggest that BPD is a stable condition where symptomatic remission is possible and the likelihood of recurrence or relapse is quite low, so it's very clinically promising. However, there are ongoing difficulties with functioning, with only about 35% of participants from our review actually engaged in a vocation at follow-up. From the consumer perspective, we found that first and foremost, there needed to be an active willingness to engage in the recovery journey. So consumers discussed how this could be initiated through engaging in meaningful roles and vocations, whether that be just engaging in daily activities or going to school or going to work. But there also needed to be a sense of motivation to not be defined or defeated by the disorder. And this was seen to be developed through gaining a greater understanding of the disorder, but also finding new ways of communicating their inner states and needs. And it was also seen that this active willingness to recover was a prerequisite for change in other recovery dimensions, including the reduction of symptoms. One of the interesting findings that we had from the review was that, as you mentioned before, consumers questioned the conceptualization of recovery, particularly as to whether the word recovery itself actually encapsulated their experiences. And this was because consumers attributed the word recovery to more traditional conceptualizations, so the more dichotomous understandings, so the difference between cured and not cured, which was seen to be not representative of their experiences at all. And they also talked about how this could have implications for help seeking, as the all or nothing or black and white thinking is quite distinctive of the BPD psychopathology. However, some consumers did offer other conceptualizations such as journey, progress, or learning. However, we did see that there was a bit of a divide between what consumers wanted for recovery and also the service goals and treatment targets of interventions. So from our review, we did see that there was a much stronger focus on clinical recovery than personal recovery, which I guess is not too surprising given the severe nature of the disorder and also the impacts on quality of life. However, we do need a greater understanding of what personal recovery processes are involved in BPD, which can help us to better individualize care and also develop services that are more recovery-oriented, especially now since there's evidence to suggest that the treatment targets and consumer recovery goals don't necessarily align. There also needs to be a more holistic conceptualization of recovery. So from our findings, and it somewhat kind of reflects what you guys were saying earlier, we propose that recovery may be better understood as a subsyndromal experience where consumers are engaged in vocation and relationships whilst acknowledging that there may be ongoing difficulties with functioning. However, we still need to do more research with consumers to understand the lived experience in order to further refine this conceptualization. And finally, we know that family and carers have an increased role in caring for consumers and that they do experience significant burden associated with this caring role. However, there is also some research to suggest that carers and consumers may not always be on the same page, and sometimes they may attribute different factors as to why their loved ones may or may not be recovering. And this has also similarly been seen in clinicians, where misunderstandings as to what recovery actually means to consumers has been seen as a barrier to promoting recovery and may also impact on the therapeutic relationship. So definitely needs to be more research in that area as well. But I think this review gives a really good overview as to how recovery in BPD has been represented in the literature. However, there are a number of questions and issues that have arisen from this review that needs to be looked at further. So when we look at outcomes following a course of treatment in the research literature, often the measures that we use have been predefined and predetermined by researchers that involve a series of different clinical questionnaires and interviews. However, these might not always, include the consumer perspective in it. And since we now know that there might be a bit of divide between the two, it kind of begs the question of what kinds of goals do people with BPD have when they're entering treatment? So we recently did a study on this to look at this further. So we looked at the treatment goals of 102 individuals who were diagnosed with BPD, who were seeking treatment at a specialist service. We asked them to freely generate 3 treatment goals or identify 3 areas that they were struggling with and wanted to work on in therapy. So the goals were transcribed verbatim, and we then content and thematically analysed these goals to identify the key themes from the participant responses. So the participants that were included in the study were predominantly female with an average age of about 30 years. And when we analysed the goals, we identified that within one goal, there was often multiple components. So say, for example, this is a very simplistic example, but a participant may say that they want to reduce their anxiety in order to go back to school. So that one goal has 2 components, to reduce their anxiety and to go back to school. So what we decided to do was to break down all the goals into its individual components. And we identified that there were 464 individual goal units, which could be categorized over 4 key themes. So developing a greater sense of self, having better interpersonal relationships, having improved well-being, and also reducing symptoms. So reducing symptoms, of course, was the most commonly cited goal area, whilst having a greater sense of self, or kind of understanding who they are as a person, was the least commonly reported goal. So this table gives an indication of the type of treatment goals and recovery goals that people had. So the first column is the key theme. So there were the 4 that I just talked about, but we could also break down these key themes into subcategories. So that's the second column. And the last column is some examples of what participants had said in their goal interview. So the first theme was associated with developing a greater sense of self or having a greater sense of identity. And this was made up of 2 categories. So firstly, having a greater sense of personal awareness, which was associated with being able to better understand themselves so that they could kind of determine what meaningful life direction that they wanted to go down, and also having motivation to kind of do that. And secondly, attitudes towards self. And a lot of consumers, or a lot of participants, talked about this in terms of needing to develop greater self-esteem and self-worth, which was seen to be a process of becoming more comfortable with oneself. However, it was acknowledged by some participants, that that this takes a lot of time and it may extend beyond the timeframes of psychotherapy. So the next theme was to do with having better interpersonal relationships. So this included goals such as improving their current relationships and most commonly like relationships with their significant others, friends, families, and their mothers. But it was also reported that they wanted a sense of connectedness, and we saw that this occurred on a continuum from being able to relate to others, whether that from being able to develop relationships, whether that's more intimate relationships or friendships, to being able to connect with others within pre-existing relationships, to becoming able to relate to others. And that was very much seen to be through fostering greater communication and understanding between the two parties. We also had some participants talk about their desire to improve their parenting capacity and also to build up on their interpersonal skills. The third category was associated with improved well-being, and so this had a little bit of overlap with some of the personal recovery findings that we had from the review before. However, we did find some additional categories such as being able to solve specific life situations that was happening at the time for the person, improving physical health within a general sense, but also being able to stay out of hospital or come off medication, and finally also coping style. So coping style was seen to be the most prominent subcategory within the entire study, and it was very much about being able to control emotions and being able to tolerate and cope with distress whilst developing a wider repertoire of coping skills and strategies. And the final theme was to do with reducing symptoms, and this included things like suicidality, impulsivity, depressive and anxiety symptoms, eating-related issues, and also transient symptoms, where the most commonly cited goals was associated with improving negative mood and thoughts, reducing self-harm behaviours, and also reducing suicidality. So I guess that gives a very quick overview of some of the goals that we identified in this study. I guess some of the interesting things that we learnt from this study was that the consumer treatment and recovery goals really did extend beyond the reduction of symptoms, and it really touched on more of the personal recovery side of things. So having relationships, being able to understand who you are as a person, and also kind of just being in a state of well-being. And the interesting thing was that about 85% of participants had at least one goal that was to do with the personal recovery side of things. So clearly, the personal recovery of consumers with BPD is a really important issue, yet we still don't know very much about it. Another interesting finding is that when we compared the goals we identified in this study to some of the other goals that have been identified by other consumers with severe mental illness such as schizophrenia, we found that the goal content was similar, so the categories were similar. However, the manner in which they were conceptualized differed a little, particularly in terms of identity and relationships. And I think that's also got to do with how BPD develops and the psychopathology surrounding that. And finally, one of the clinical implications of this study is that we really need to routinely be asking our consumers what their goals for recovery and treatment are, on top of all of the other outcome measures that we take. And I think this can provide us with a good indication of how people with BPD are travelling in terms of personal recovery, and it also gives people more of a voice. But I guess we still don't know very much about how consumers define recovery, and there's been very little research on the lived experience of consumers. So we're about to start a new study looking at journeys to recovery from BPD. So we're currently we're currently inviting consumers with a diagnosis of BPD who believe that they're in either a state of recovery or currently experiencing wellness to really contact us. And if you're willing to share, I do encourage you to participate. So my contact details are there if you're interested. Thank you.
Thank you, Fiona, for that lucid presentation. We have about 5 minutes to discuss. Maybe I'll invite Brent to make the initial comments. I saw that you're also a co-author on this paper.
Thanks, Sasya. Look, I think the issue to us is a little bit like the stories this morning and also the consumer and lived experience. We've still got a lot to learn. And even though we did do a systematic review of over 1,000 patients, I don't think that we've necessarily uncovered all of the issues yet. So I think these kinds of studies are going to tell us something new. So I'm interested to listen, and I hope those who have got something new to say will be part of it.
Yep.
Did you look at neurology studies at all with the patients who were looking at recovery?
No. So we predominantly looked at longitudinal studies that, so they follow the natural course of the disorder. So I think people are just followed up every so often. We also looked at studies that looked at the consumer experience, but we only found 3 studies that looked at that. So we didn't look at
So you were
neurology.
just looking at studies, not like, you didn't do your own, you just looked at various studies?
No, so the first study was a review, so that is a review of the entire BPD literature.
Right, sorry, we came in later.
No, that's okay.
But while I'm here, I may as well ask this question, that what concerns me in the mental health area is that no one ever looks at the brain to see whether, you know, what bits are working and what bits are, you know.
Yeah.
And I find it difficult to understand how studies can be adapted when we don't really know what's in which part of the brain. So if you had a hemorrhage, for instance, you'd be looking at the brain to see which part where the hemorrhage is or whatever. But in mental illness, we don't do that. And yet we make assumptions. And I do find that very, very difficult to...
Yeah, I think there's, you know...
I get your question because, see, the concept of recovery itself is a medical, it comes from a very medical model. If you're looking at someone having an infection, you can recover from it. But if someone has a BPD, recovery itself is a very controversial concept. But we have not progressed that far in mental health, and definitely not in borderline personality disorder, to be able to measure brain changes and looking at recovery. Not to the extent, my understanding, not to the extent that Fiona was talking about. What we are able to measure and talk about is symptoms and functioning. But I get your point. But that would be really the true point of recovery.
Sorry. I guess I was going to say, and I know there's quite a lot of overlap, and some people say it's the same thing. Like, I'm quite interested in complex trauma, the concept of complex trauma, and some people argue that BPD should have been renamed complex PTSD. And there's certainly a lot of sort of neuroscience sort of research happening there. So yeah, if you sort of look at that stuff, then they very much are looking at the actual brain structures involved and that sort of thing. So I think that's where that's happening.
I've been on this road now for 15 years, but with another diagnosis of schizophrenia. So I'm coming into this, I'm coming into borderline totally as a new girl on the block. But I just think that clinicians are not changing. I mean, I would love clinicians to say, let's look at it in a different way, you know. Are we going over the same material over and over and over again that we did in schizophrenia, but we're not looking at the brain as a whole to see, because you can with neuroscience. And Right, right. No, no. And is like I look at my daughter and she is totally traumatised. Totally traumatised. But all people want to do is shovel medication in or not give her medication and then say, "I'll see why she's not well because she doesn't have medication." And it's very, very frustrating as a parent. And I think, I mean, like, we're not in the 1950s.
I would love to see brain changes, and because we can give a pill and do a treatment, and coming from a medical perspective, that would be easier. I think we are still not there yet. That's my understanding. Is there anybody else who wants to comment?
There was a question down the front.
comment on that. So yeah, my understanding would be there'd be a lot of evidence that you would be able to find around trauma. However, I am very interested in seeing that things like borderline personality disorder aren't pathologised greatly as schizophrenia has been, and I think the consumer movement around people with a psychotic disorder trying to arrest back ownership of their own stories and their experiences of recovery around psychosis and move it away from a disease model of schizophrenia is something that I don't want to see people with complex trauma go through with borderline.
I think we have run out of time. We'll have to finish up. What we discussed is that there are several perspectives. There is a perspective of the consumers, the perspective of carers, the perspective of clinicians, and the neurobiological kind of perspectives. So they're all very interesting views and ideas, but so it is a new area still for us, very new area. We're just about talking about symptom remission. Hopefully we'll get there. Okay, let's stop on that optimistic note. Thank you. Thank you, Fiona. As a mark of appreciation from the foundation, a small gift for you.